How are you all doing? Thanks for having me back. This is kind of one of the highlights of my year. So I love coming out and chatting and trying to, bring some awareness to the heart, because so many people, have heart disease, and so many people have questions about it. So what I want to talk about today is one of cardiologists, or as a cardiologist, one of my favorite subjects, and kind of one of the general public's least favorite subjects, and that's heart attacks. We've never really talked about that here together. We've talked about a lot of preventive medicine, how to avoid heart attacks, things like that. But we've never really talked about what is a heart attack and what causes heart attacks. And then we're going to spend a little bit of time at the end talking about prevention, because that's the best heart attack to have is no heart attack. You'd rather not have one in the first place, and what can I do to avoid it? And then unfortunately, if you do, what does that mean for me for the rest of my life? So a really common thing that happens in my clinic is somebody is referred to me and they say, "Doc, I had some chest pain." And the first thing that went through my head was, did I have a heart attack? Because that's kind of the natural thinking, you get a pain in your chest and you go, is this a heart attack? Is this the one? How do I know? And so one of the problems of chest pain is that there's a lot of different causes. Now, on that list are heart attacks. Now, the official name of a heart attack is a myocardial infarction. Myocardial just means heart muscle. Infarction means damage. So I will sometimes say heart attack, and I'm sorry, sometimes say myocardial infarction through this talk, but it's the same thing. So a heart attack definitely is a cause of chest pain, but so does angina. So angina just means you're having chest pain because you got a blockage. It doesn't necessarily mean that you had a heart attack. The definition of a heart attack is you close off an artery for some period of time, and it causes damage to your heart. There's plenty of people that come to the office and say, well, gee, every time I walk up the basement stairs, I'm getting this heaviness and chest pain, and that's just angina. And that may mean you have a blockage, means we may have to do something about it, but it doesn't necessarily mean you're in the midst of having a heart attack. But also, I think I got the other causes can be reflux problems, belly problems, spasms in your esophagus, which is your swallowing tube. You can have pain in the chest wall. You have had trauma, like, somebody came up and hit you in the chest. Lung issues can happen. So my little ... there is, this list could go on for this entire talk as to the causes of chest pain. So not every chest pain is a heart attack, but if you look at the things on this list, the heart's up at the top. And so when you have chest pain, we have to be sure that that's not from your heart. Now, we're going to talk about the symptoms that can suggest a heart attack as we go forward here. But, most times the chest pain of a heart attack is described as a heaviness or a band around the chest. Lots of times it's associated with other symptoms. So these are kind of the most common things that are described for heart attack pain. So you'll have pain in the chest. Lots of times it might go into your neck. Frequently goes into your shoulder, left most commonly, but I've seen it go to the right, but most commonly to your left, down your arm. You'll probably feel short of breath, and you'll just be standing there. It's not an exertional thing. Where we talked about angina, that tends to be shortness of breath when you exert yourself. Heart attacks are more frequently shortness of breath at rest. You may feel lightheaded, you may actually break out into a sweat, or you may get nauseous and vomit. Now, that said, the classic symptom of an elephant sitting on your chest is actually described in men 50 years ago. So this is not always the way it presents with women. So in women, we need to also look at some other symptoms that can go along with it. Now, can women have classic brick sitting on my chest, short of breath, I broke out into a sweat? Sure. But frequently women don't. And so what I've noticed in women is pain that goes into the neck and jaw is far more concerning to me when I hear that from a woman, because a lot of times their pain will radiate up. They may have pain in their shoulders or pain behind their shoulder blades. Definitely they might feel indigestion, and they will very frequently describe extreme fatigue, like I woke up this morning and I don't know what happened overnight, I'm so tired. So there are additional signs you need to look for, particularly in women. Now, everybody here might be too young to remember Fred Sanford, but old Fred, you remember, used to, have those signs. I don't know if my little video works. No, my video doesn't work, but that's old Fred. Always, every episode, I'm having a heart attack. I'm coming to get you. And so we laugh at that, but it's not without its truth as far as the symptoms that you might have. Now, Fred just did it to get out of bad situations, but if you have that kind of symptom, I want to know about it. So, there are multiple kinds of heart attacks, and we're going to go through each of those. The ones we're going to talk about mostly is called an ST elevation MI, or a STEMI. And you say, why is it called that? Because it has a characteristic finding on the EKG. And you're going to learn some about EKG today. I didn't know if you knew when you came here you were going to get some EKG training. Now, there's also a non-ST elevation MI, which just means that part of the EKG is not abnormal. And so that's a little more tricky, and we'll talk about that. There's another one called a vasospastic MI, which is also called Takotsubo's cardiomyopathy. Why Takotsubo? Because a fellow from Japan discovered it, and his name was Takotsubo. So this is kind of the broken heart syndrome that you may have heard about. If people are in a very stressful situation, that it can induce a heart attack. But it's not because you have a blockage. It's not because there's plaque there. It's because your arteries kind of spasm down on top of each other. And then a newer thing that we're starting to notice is a thing called a spontaneous coronary dissection. That basically means you have a tear in your artery. And we're seeing more of that. Now that tends to be in much younger people. You'll see it in 30-year-olds. You don't see it as often in more seasoned patients. But it'll look just like an ST elevation heart attack. You'll go in and look at it, and it'll just be a tear and not a plaque. So I wonder if that'll. Can you click that and see if it'll run? No, it won't run. Okay, so I was going to show you some pictures of some of hearts that pump. This was just going to be a picture of a heart that kind of pumps normally. All the walls come in together like they should. Next. In Takotsubo's, and we're going to not talk too long about that. It's due to a spasm of the artery. It's brought on by stress, emotional situations. I took care of a lady who was an aerobics instructor, but she was going through an ugly divorce, and that kind of brought on this Takotsubo's. It's much more common in women that are particularly younger. We treat that with medicine, and thankfully it's got a low mortality. Patients are sick kind of on the front end, but by the time you treat them with medicine, the heart kind of goes back to normal. So we are seeing more of these types of things. In that case, the heart, instead of all the walls coming in, if you think of the heart as a football, but the football's only got one point on it, the football is not, the point of the football is not moving, but the whole top is. It's because all of the arteries are spasming at the same time. But let's move on to some things that we really are probably more concerned about. I had a picture of it. So we're going to do a little EKG training now, okay? So this is a normal EKG, and you can see all the tall hills. And if you look closely, you'll see there's a little hill before the big hill, and then there's kind of a medium hill afterwards. So those have been given names, and I don't know why they got called this, but the small hill is called the P wave, the tall hill is called the QRS, and then the medium hill afterwards called the T wave. And so what we're very much interested in is that little flat segment that goes just after the tall hill and just before the medium hill. You'll say, why? Well, I'll show you why. So if you see here, you can see that that segment that was from the tall hill to the other hill now looks much higher on the EKG. So this is an anterior MI, means the front of the heart is what's being damaged. So when somebody comes to the emergency room, we get this EKG, they're having an acute heart attack, time to do something. Now you can also have similar things. If you look over here in the leads labeled 2, 3, and you can't see the AVF, but over here on the left, you can see that the ST segments are elevated there. That's called an inferior MI. That's more the bottom of the heart. And then the third kind I want to show you, and these can hide, they're difficult, is a posterior MI, meaning it's happening on the back of the heart. And you can see in those first 3 lines, 1, 2, and 3, the ST segments are not elevated, they're actually depressed. You know, it's almost like you dug a hole there. So all of those types of EKGs are signals, hey, we have an emergency on our hands. And there is this thing that we call tombstoning, that the ST segments get so high that that whole thing starts to look like a tombstone. And that's a bad sign. So we want you to get to medical help, to the closest hospital you can get to before we develop that. That means that the damage is extensive. So, quick, let's talk about non-ST. So if the patient comes in, they're having chest pain, and their labs say, oh, there's been a heart attack, but the EKG doesn't show anything. So I think there's probably a lot of times where people get admitted to the hospital for a lot of other things, and the staff will tell you, oh, you had a heart attack. Well, I'm here with a urinary tract infection. How did I have a heart attack? You know, or I'm here with pneumonia. How did I have a heart attack? And so part of the reason is we use the EKG to diagnose a heart attack, but we also use labs. And so there is a specific lab that the ER gets frequently called the troponin. A troponin is an enzyme that lives within your heart. It's usually not out in your blood. But when you come to the emergency room, they like to throw out a wide net. And so they'll test for a whole bunch of things to try and figure out what's going on. And sometimes your troponin will be abnormal. So let me give you a little math equation. An elevated troponin, when you have a heart attack, your troponin is always elevated. That is true. When your troponin is elevated, it doesn't always mean you had a heart attack, but people will say that. And so frequently, people come into the hospital with other illnesses. They can be septic, infection, a pulmonary embolus, which is a blood clot in your lung, pericarditis, which is an inflammation around your heart, really low blood pressure, really high blood pressure, really fast heart rate. All those things make the heart work harder. And so you'll see this troponin in the blood. It won't be that high, but it makes you at least go, hey, what happened with the heart? That doesn't mean you necessarily had a heart attack. It may just mean that your heart was under a lot of stress. Now, it can be because you have a blockage that you didn't know about, but that can be sorted out once the primary problem is fixed. So you may not have to have an angiogram at all, and we usually treat that with medication. Number one is to treat the primary problem you're in with. Now, let's get to ST elevation. This is kind of the most feared of types of heart attacks. So this is due to an acute closure of the heart artery. And I showed you the EKG changes we see. And there's I don't know how much people follow this, for years, people didn't know what to do. So 40 years ago, if you had a heart attack, they kind of threw you into bed and said, stay there for a couple of weeks and don't do anything. And it was kind of survival of the fittest to see if you were going to be able to make it, which is not a great way to treat a heart attack. So after that, something came along. You may have heard of a thing called clot busters. So clot busters were a medicine that they would put in your vein, and it would dissolve the clot that was causing the problem inside the artery. So for a long time we used clot busters, and particularly in rural areas. You know, here at Coosa Valley, we have come up with a method where if you're having signs of a heart attack, we'll either take you to the cath lab here at Coosa Valley, or if it's in the middle of the night, we'll transfer you up to Grandview, you know, to get that artery acutely open. It has been found that if you take the patient emergently to the cath lab and do an arteriogram, open that artery up, and put a stent in there, you have the best outcome. But you may see cases where you're in the middle of somewhere in the desert in Texas and you're having a heart attack. Better to get some clot buster and then get to a hospital than to just, you know, let it sit. So what causes heart attacks? So on the left there, we see a fairly normal artery. The arteries have muscle around them, and then over time, plaque builds up. That's based in cholesterol, but it also has to do with inflammation. And that plaque is sitting there, and it inhibits blood flow. Now, plaque by itself doesn't necessarily cause the heart attack. If the plaque has a problem and ruptures, then that can cause the heart attack. A lot of times people that have buildup of plaque will have angina first. They'll say, I was fine, now over the last month, I could walk a mile, now I can't walk more than about 100 feet, I get chest pain, and that we'll go in there, we'll find there's a blockage and we fix it, but that's all under very controlled conditions. The biggest problem is sometimes those plaques can become unstable. We don't know why that is. There's a lot of science being done right now to figure out how can you look at a particular plaque and know that it might become an unstable plaque. And so what happens is that plaque ruptures. And when it ruptures, your body says, well, there's damage there. So just like if you cut yourself on your arm, you know, over some time, you'll notice that blood starts to get sticky and the bleeding stops in the cut. That's because you sent platelets there, which then made their blood clot come, and that's how you quit bleeding. It's the same exact mechanism as when you cut your arm, but the problem is you're inside of a closed tube now, right? So there's only so much room for the clot, and once the clot takes up the entire surface of the vessel, then there's no blood flow, and that's when you have to do something about it. So what's the best way to do that these days is to go to the cath lab, have a cath. Some people call it an angiogram, some people call it a left heart catheterization, all the same thing. We'll go in there, we'll find where that plaque has ruptured, and then we'll put a stent in. The stent is loaded on top of the balloon, and we inflate the balloon. Balloon gets deflated, stent stays there. It's like a scaffold for the inside of your artery, and now you've got good blood flow back. So when you get to the cath lab, you'll take some pictures. I'm going to go past that. But you can see here on the left, where the arrow is, you can see that artery suddenly stops. So that's where the plaque was, that ruptured. The clots closed it off. And now, with those three arrows, you can see you open it up, you put the stent in, and now you've got blood flow restored. The faster that happens, the less damage there is. So, if you have persistent symptoms, like we talked about, you know, a one-time little short chest pain is probably not anything to worry about. But if you have those ongoing symptoms, like we talked about at the beginning, you are best served. Come to the hospital, get an EKG, make sure things are okay. Similarly, you can see here, this is now the right coronary artery. On the right, you can see there's nothing, blocked off artery, you now open it up, put the stent in there, and get blood flow back to the heart. So the sooner you can get blood flow back to the heart, the better off you are, the least amount of damage will be caused. So let's talk a little bit about what are the risk factors for heart disease. And really, these are the main five. These have kind of been the main five for 40 or 50 years. Lots of people these days are looking for other unidentified risk factors. But if you concentrate on these five, you'll be best served in reducing your long-term risk. So definitely, I think the two most important ones are smoking. Smoking definitely increases your risk of a heart attack. Unfortunately, diabetes does too. Diabetes is not just a sugar disease, it's an inflammation disease. So everything gets inflamed in your body. That's why we have to check your eyes when you're diabetic. That's why we have to check your kidneys when you're diabetic. Because all your blood vessels get inflamed, and that inflammation makes you more prone to these plaques occurring there. Hypertension, which is high blood pressure. Hyperlipidemia, which is cholesterol levels. And then the fifth one is also a very important risk factor, and it's one that we take very seriously, and that's a family history. Mom, dads, brothers, sisters. If there's a history of heart attack, particularly if it happened prematurely, somebody in their 50s or something had a heart attack in the family, we take that very seriously. Unfortunately, the top four are called modifiable risk factors. There's things you can do to lower your risk in those top four. Unfortunately, your family history is your family history. You're born with the genes that you have, and so you don't even know whose genes you got for heart. Was it your mom? Was it your dad? But we take it very seriously. So in patients that have a strong family history, we probably get a little more aggressive on the front end. So how do you treat this? First off, you get to medical attention, you get an arteriogram, you get your heart fixed with a stent. On occasion, people have to have bypass surgery, but that's becoming more rare through the years. So what we'll do is we'll treat you with blood thinner, aspirin, and if you've got a stent, we'll give you some other blood thinner with either Plavix, Effient, Brilinta. You take both together. The aspirin is forever. The other one is usually 6 to 12 months. We treat with statins and other lipid agents. We're going to talk a second about statins because statins have a little bit of controversy surrounding them. We'll give you beta blockers, which are things like metoprolol, atenolol, bisoprolol, all the alols. We give you that for a couple of reasons. Number one, it lowers your risk of a rhythm problem after you've had a heart attack. Number two, it helps your heart to recover, takes the workload off your heart. So at least for a little while after the heart attack, we like to put you on beta blockers. And then lastly, we usually recommend cardiac rehabilitation, which is kind of a supervised exercise program where there's a nurse, they'll monitor your blood pressure, you'll wear an EKG monitor while you're doing it, but there's very good evidence that getting into a cardiac rehabilitation program actually gets you better faster. We have a really good cardiac rehab program here at Coosa Valley. So that is a big part of treatment of this. Now, aspirin over the years has become a little controversial. You may have seen stories on the news or on the television about aspirin and should we take it? So there's really two groups of people here. There's what we call primary prevention. That means I never had a heart attack, I never had a stroke, and I'm just trying to prevent my first episode. Then there's secondary prevention. That means I had a heart attack, or I had a stent, or I had a stroke, or I had a bypass surgery. And in those cases, in secondary prevention, you've had something. No one argues that taking an aspirin is helpful. And if you look here on the left side, it shows all these things that we want. Again, these are patients that have had some event. It helps against major coronary events, a recurrent MI, stroke, vascular death, any serious. The problem is the cost is an increased risk of bleeding when you take aspirin. But it lowers your risk of having to have another heart attack or having a stroke. It helps. In primary prevention, where you've never had anything, there has been a real controversy because aspirin does lower your long-term cardiovascular risk by a little bit, not as much as this, but a little bit, but you still have the bleeding complications. So, American Heart Association has come out recently and said, well, each patient, we're not recommending aspirin for everybody for primary prevention of a heart attack. So what we have to do in those cases is kind of look at your risk factors. If you're diabetic, you're smoking, your blood pressure's out of control, and your cholesterol's high, and you never had a heart attack, you probably benefit from aspirin. But if you don't have those things, you might not. So you need to talk with your doctor about whether aspirin for primary prevention, meaning preventing that first episode, is helpful or not. How much aspirin? I get this question all the time. So a baby aspirin is 81 milligrams. Adult aspirin is 325 milligrams. And so they looked at, is there a difference in doing those? So in the top panel, you can see that the blue and the red line really just kind of are on top of each other. So that's comparing 81 milligrams of aspirin versus an adult aspirin. And basically what they're showed is the risk of death, hospitalization for another heart attack, or for stroke was equal. So they were equal in preventing future events. But if you look down on the bottom, you can see after you've been on the adult aspirin for quite a while, the bleeding risk starts to go up over taking a baby aspirin. So a baby aspirin is what you need to do if you're prescribed aspirin, and it's sufficient to keep you from having another episode and lowers your risk of bleeding. Now let's get to the other piece of controversy. Statin drugs, the Lipitor, atorvastatin, rosuvastatins, pravastatins of the world. So if you're a computer person and you go and you Google statins, you're going to get about 150,000 websites that tell you how bad statins are for you. Look, statins aren't perfect. Statins can cause people some side effects, and so they're not good for everybody. But if you look at the top line, this is now incidence of death. On the red is people that don't take statin, and on the blue is the people that do take statin. And if you notice, right down here in this corner, those curves start to separate at about 6 months of time. That's years on the bottom. So if you've had a heart attack and you take aspirin, at 6 months you've already improved your long-term survival. And if you look, those lines just keep getting farther apart from each other. So in patients that can take statins, I'm not a guy that's gonna grab you by the shirt and force you to swallow it, but the data is clear that statins lower your risk and increase survival long-term after you've had a heart attack. Off the heart attack, there's actually data out there for people taking statins who have high cholesterol that it actually lowers your risk long-term even if you've never had a heart attack. So statins are the cornerstone of therapy for cholesterol. Now, there are other drugs out there now, some injectables that have been shown to lower risk. So in patients that do have a problem with statins, muscle aches, liver enzymes go up, whatever reason, there are alternatives out there, but none of them are as good as statin therapy at this point. So, what can you do? None of us want any of what I just talked about. We want none of it. I'd rather nobody in this room have a heart attack, because by definition, a heart attack is damage to your heart, right? And so when you damage your heart, heart's kind of like the brain. Once you damage a portion of it, it doesn't come back, it doesn't grow back. Things like your liver, they'll take half your liver out, transplant it in somebody else, and your liver grows back. But heart cells are not programmed that way. So when they get damaged, there's no new cells coming to the rescue. So we want to avoid damage to your heart in the first place. And if you do have a heart attack and the heart gets damaged, well, then we spend a lot of time trying to get the rest of your heart to make up for the area that was damaged. The problem is, once it's damaged, if it's damaged a lot, then you might have survived your heart attack, but then you're stuck with heart failure. And we really want to avoid heart failure because that's not a great way to live if we don't have to. So one of the 4 things you can do: quit smoking if you smoke, or at least reduce as much as you're smoking. If you're diabetic, get your blood sugar under control. If you have high blood pressure, get it down. And if you have high cholesterol, get it down. All these things will help to prevent, or at least reduce the risk of having a heart attack in the future. Now you say, well, what's the, I have a heart attack, is that going to be the end of me? So, no, it's not. If you look back 40 years ago, the mortality rate for a heart attack was somewhere in the neighborhood of 35 to 40%. About 60% of people survive long term. And so now with current technology, with current medicines, with getting people to the cath lab early and opening up their artery, you can see, so the blue line on top is from 2003 to 2006. The red one is 7 through 10, then 11 through 14, then 15 through 18. And as you can see, over the years, with better technology, better ways of getting patients quickly to the cath lab, and with better medicines, we're bringing the mortality down to the mortality rate now is somewhere in the 6% range. So that's not zero. So we don't want to test the system, but mortality rate has definitely come down. And so I don't want you to feel like, oh my gosh, I had a heart attack and now I've got to go sit on the couch for the rest of my life or count the days until I call the undertaker. That's not how it is, okay? We can help you, we can work through this and get you back to a normal life. So that gentleman had a heart attack 6 months before that. He's now out riding a bicycle, living a normal life. So again, number 1, prevent. Number 2, if you have a heart attack, there's a lot we can do about it, but you can't ignore the symptoms if you're having it. We need to get to you quickly, and then you can have go back to a normal life. I appreciate all your attention, and I'm happy to take any questions.
Okay, guys, you got questions? Okay, Mr. Ron?
I have one question. If anybody's familiar with the internet, you see a lot of different ads for whatever you want to call them, homeopathic remedies,
Sure.
not medications.
Sure.
But like beetroot and other things that say, you take these and it will just clear those arteries.
Okay, so we have no evidence of anything that's going to just clean your arteries out. There used to be this thing called chelation, where they give you these, whatever it was, in the bag, and it's going to clean up your arteries. There's one study ever that's been shown to reverse plaque in your arteries. And they used a medicine called Crestor or rosuvastatin, and they gave it to patients at 80 milligrams a day, which is double even the dose that's available. And they showed a slight decrease in the size and thickness of the plaque. So, but that study's never been repeated. It's not using medicines at approved doses. So, at this juncture, no, there's no evidence. Now, I am not against natural remedies, things like that. I think that the problem with natural remedies, homeopathic, whatever you want to call it, is we don't have a lot of double-blind studies to tell us. So I'm kind of here, the way I deal with that or live with that is, I have no problem with you taking anything if it's not harmful, because it may help you. And there's this whole issue of inflammation that we talked about. Nobody knows, right? How do you reduce inflammation inside of arteries? And so there's a lot of claims with homeopathic things that, yeah, it can reduce inflammation. Yeah, maybe it does. And so, but short of having a double-blind study, it's hard to say. So I'm not against it in any way. There are a few herbal remedies that I don't like because they have other side effects, you know, like ginseng can raise your blood pressure. Other things can increase your bleeding risk, like ginkgo. So, you know, but far and away, most of those type of things, I'm fine with. And if you feel better on them, perfect. And if they're not hurting you, perfect. And if it helps you, even more perfect.
Okay, any other questions? Okay.
A question about hypertension. If hypertension is controlled with medication, is it still a risk factor?
Yes. So, but less so, right? So the lower you get your blood pressure, the less workload there is on the heart. So the problem of high blood pressure is twofold. High blood pressure, let's say uncontrolled, makes your heart work hard. And your heart is a muscle. It's just like any other muscle. And so, you know, if you're in the gym and you're lifting weights, your muscles get big. And so the heart, when it's having to push against that extra pressure, the muscle gets thicker and thicker and thicker. And so what happens is you don't get more cells, you get bigger cells. And if you look at the wall of the heart, it gets thicker and thicker. Well, the plumbing's got to still bring the oxygen to the muscle to make it do its work. And so now you're asking for more oxygen, and if you have a blockage in that artery, you're not able to keep up with the demand. You know, your heart is kind of a supply and demand organ. And the demand is the workload, and the supply is your coronary arteries. And if your coronary arteries are clean and open, well, you can keep up with it. But if you can't, then you have a problem. So if you lower the pressure, that thickening, that demand on your heart goes down. And that's how it actually reduces your risk of a heart attack.
But it doesn't go away.
No, ma'am.
If you have ever had high blood pressure before you got on medication,
You have to consider it a risk factor. Now, I will say, if it's been well controlled throughout your whole life, then I think, you kind of chalk it up and say, okay, you've had it, but I'm not, and if that's your only risk factor, I'm not going to get too aggressive over that. Yes, ma'am.
Would you explain congenital heart failure?
Congestive or congenital?
Congestive.
Okay, so congenital heart disease means you were born with a structural problem. Congestive heart failure, it's kind of a clinical term. Congestive heart, and it's one that gets thrown around a lot. So if you show up at the hospital and you're short of breath, and then maybe there's a little fluid on your lungs, you kind of sometimes get labeled with congestive heart failure, and it never seems to be able to outrun it. But congestive heart failure is, I don't like the term because it's not very descriptive. Why do you have congestive heart failure? Why is your heart not pumping like it should? So you can have congestive heart failure because your heart's weak. You can have congestive heart failure because your heart's stiff. You can have it because you have a valve problem. You can have it because you have a rhythm problem. So it, as a term, to me, is not very descriptive of what's going on. But it basically means any heart condition that is making you hold on to fluid, get fluid on your lungs, you might get swelling in your legs, but it's not very descriptive of why. And then, because the whys are different, right? If somebody comes with new onset congestive heart failure, first thing you have to ask is that due to a blockage or is it not due to a blockage? So we do a heart catheterization. No, you don't have any blockage. So you're in this group that doesn't have it. Well, what caused it? Did you have a toxin? Did you have a virus? Are you genetically prone to it? So I think you have to dig a little deeper than just accepting the word congestive heart failure. Because it's really I don't know if you know the word gemisch, big, ugly mixture of various different conditions that all tend to look the same clinically.
All right. So, Dr. Schultz, can you talk just a little bit about the great cath lab that we have in Coosa?
Yeah.
What it does? I want to make sure people know we can take care of your heart in Silicaca, Coosa Valley Medical Center.
Yeah, so we have a cath lab. We're a full-service cath lab. We just have one cath lab. You know, you go up to Grandview and there's 12. But we don't need 12 down here. We have one. We do heart caths there. We put stents in there. We work on peripheral vessels like your legs, or if you have blockage in your kidneys, or blockages out in your arms. And we will take you to the cath lab if you come to the emergency room and you're having a heart attack. Now, I'm not here 24/7, and so sometimes if it's in the middle of the night, we'll send you to Grandview where we have a 24-hour cath lab. We don't have that here. But we've expanded what we're doing here quite a bit, I'd say, in the last 3 or 4 years, so that people, you know, can get what they need done here. And then you're closer to your family, you're closer to your house. And so there's most things, I would say, 90% of what I was doing up at Grandview, I'm doing here. There are some things when you get in there and the artery's gonna be tough, it's gonna be a little higher risk. We'll send that up to Grandview to fix. But the lion's share of things we can fix down here.
Yeah, with an amazing team, with people that care about you, know your name, they're going to take great care of you. So we are so fortunate that I will say over the last few years that our cardiac services have just grown and grown and grown. And finding the right physicians was a part of that. So we're thankful for you, Dr. Schultz. And all of our cardiologists, we have 2 groups in Silicaca, and they all do an amazing job. Now, I can't close out today without recognizing Mr. Jeff Harrell back there. So Jeff, because everybody knows and loves Jeff.
So Jeff is our nurse practitioner. And, Jeff's our nurse practitioner who spends most of his time in the hospital. So, you know, when you get him into the hospital or the emergency room, he'll probably be the first face that you see. Gather up all the information, and then we'll come see you. Tim Crump, go ahead and stand, Tim. Tim is he's not a new nurse practitioner. He's been at this for about 25 years, but he's new to us. He and Jeff actually trained together years ago, so he's been doing cardiac for years, and now he's in our office. Since I'm down here full time, we've got a full, you know, cadre of patients, so it's not possible for me to see 60 patients in a day. So we've got Tim who's helping us out in the clinic. So you may end up seeing him on occasion in the clinic. So the 2 of them are just invaluable for helping me down here.
So we are so fortunate to have this team that's helping take care of our hearts. So do you guys remember if you were here last year, Dr. Schultz was in a wheelchair? Look at him now. Let's give him a big hand. Okay, thank you.
So
I'm going to get our team to come. I know y'all want to see what's in these buckets. A few of us don't win a prize. So we'll be back the first Monday of March. Oh my goodness, well, I'm going to spring. And we'll be having a really good time. So today has been a great day. And I'm looking for a fun time in March. So again, while they're getting ready, just remember a fabulous cardiac rehab program. I hope you don't end up in Birmingham, but if you do, you can, or wherever, I just say Birmingham, it's closest, but you can come home to do that cardiac rehab. Has anybody ever used the cardiac rehab services at Coosa Valley? Well, good for you, but they are fabulous. So make sure you remember that, and then our great cath lab. And again, thank you so much for being here, and I'm going to turn it over to the girls.